Okay, I want to welcome everybody back. We will start session number 6, minimally invasive techniques in malignant tumors. I'm Mario Stan, and I'm here with Dr. Roberto Negro. We will chair this session, and we have a few excellent speakers. And we will start with Dr. Stephen Hodak. Dr. Hodak is coming from NYU Langone in New York, and he will talk to us about thyroid nodule profiling and risk stratification using NGS and ThyroSeq. Dr. Hodak.
A few disclosures. So this is an overview of the talk. I'll talk a little bit about the use of cytology and diagnostic uses of cytology in especially indeterminate nodules, and also point out a couple of the limitations. And then the evolution of molecular diagnostic testing, specifically a multi-gene panel approach to molecular diagnostics. This originally arose in the context of resolving indeterminate cytology, but I think now, you may have heard the excellent talk from Dr. Kloos last night. One of the new frontiers in molecular diagnosis is this idea of graded risk stratification. And what I'd like to try to do in the course of the talk is, rather than provide answers, I'd like to ask provocative questions. And I'd like to do that especially in the context of minimally invasive therapies, to ask how molecular diagnostic testing can become an adjunctive mode of diagnosis and even prognosis in this field. So as it's been mentioned several times during the meeting, we in the United States use the Bethesda system for classifying thyroid cytology. It's very similar to the Italian system, the British system. And the point of all of these grading systems is that we want to identify nodules that are likely to be benign, and they should have a very low risk of malignancy. We also want to identify nodules that are malignant, and we hope that these have a very high risk of malignancy, but we all recognize that in the middle, there's a gray zone, these nodules that are indeterminate, where the pathologist can't decide whether they're benign or cancer. And there are several different ways of classifying these nodules, but the point is they have a variable risk of malignancy, and this was always historically a problem. You know, in the old days, it was very easy. When you had a nodule that was cytologically benign, it was fairly clear what needed to be done. These nodules have a very low risk of cancer, and generally a strategy of observation, perhaps repeating a fine needle aspiration, was the appropriate intervention. And in most cases, when you had a nodule that was overtly malignant by cytology, where the risk of cancer was high, generally surgical management was offered, though more recently observational management, otherwise known as active surveillance, was always an option as well. The problem occurs in this 20 to 30% of cases that are cytologically indeterminate, where it's not clear whether they're benign or malignant. And molecular diagnostics really became the strategy for trying to resolve this type of tumor, at least in the United States, in the last 5 or 10 years. The approach to molecular diagnostics was to develop tests that had both very high negative predictive values, meaning that when the test was negative, the nodule was very likely to be benign, and high positive predictive value tests, which mean that when the test is positive, the likelihood of finding cancer or a transitional lesion like a NIFT-P was extremely high as well. But this is a very binary strategy where you're either getting chocolate or vanilla, and there's no, I guess we're in Italy, so it's spumante in the middle, spumoni in the middle. So the question is, can molecular diagnostic testing allow a more graded approach to risk stratification? So what I'm showing you here is various types of cancer: papillary cancer, follicular cancer, poorly differentiated anaplastic medullary cancer. And in 2007, when I got involved with molecular diagnostic testing, we made this observation that a very small number of genetic alterations, and you've heard of some of these already at the meeting, BRAF, RAS, fusions like RET-PTC and PAX8-PPAR gamma, were highly prevalent across all tumor types, but particularly prevalent in this 90 to 95% of all differentiated thyroid cancers like papillary and follicular carcinoma. So what we started doing in 2007 was we created this thing that we called the 7-gene panel, which basically looked at BRAF, RAS, RET-PTC, PAX8-PPAR gamma as a predictive tool for evaluating indeterminate cytology. And what we found that we had created was a very good positive predictive value test, which was a rule-in test, meaning that when one of these mutations or alterations was present, the likelihood of finding disease was extremely high. It was not, however, a good negative predictive value test because about 35% of the cancers that we evaluated did not have an identifiable mutation. It was also not cost effective because we were initially doing it with methods like melting curve analysis and Sanger sequence confirmation, which meant that every time we wanted to add another gene to the panel, it added incremental cost. That changed in 2012 with the advent of next generation sequencing, which made it possible to test one gene or 100 genes for basically the same cost. And so what we were able to do was to add additional genes that occurred with very low prevalence, but were very useful diagnostically to the panel and improve its capabilities. This incrementally improved the negative predictive value, but it still was not terrific. The positive predictive value was still a pretty good rule-in test, but it was not a good enough rule-out test. With gene discovery a little bit later in 2014, when we started doing whole exome sequencing, transcriptome genomics, we found more genes that were able to be included on the panel that again improved both its positive and negative predictive value. But the big innovation came around 2014 with the publication of the Thyroid Cancer Genome Atlas paper, which Dr. Klus referred to last night. And what this was an analysis of about 400 papillary cancers. And using various genomic and proteomic methods, these cancers were sort of decoded so that the genetic alterations responsible for oncogenesis were shown. So if you haven't looked at this kind of figure before, what you're seeing in each column is an individual tumor, and then the analysis shows point mutations, fusions, copy number variations, and then clinical correlation in this very colorful bar across the top. So what did this study show us? It showed us that in these 400 papillary cancers, about 75% of them were driven by a single nucleotide variant, a point mutation in the genes that we were talking about before, like BRAF and RAS mutations. Another 15% were driven by fusions like RET-PTC fusions, you've heard of those, PAX8-PPAR gamma fusions, and another 7% or so were driven by copy number variations where entire arms or large parts of arms of chromosomes were either lost or duplicated. And this described the mechanism for forming these cancers in about 95% of cases, and this was a critical bit of information. The other piece of important information, again, that Dr. Klus alluded to last night, was this so-called RAS-RAF score. So again, this is an important concept, and I want to go over this again. So what does this mean? Well, tumors are generally more BRAF-like or more RAS-like. And what that means is that the BRAF-like tumors are more like conventional variant papillary cancers. They tend to behave clinically more aggressively. And if you look at them on a genetic level, they lose expression of the thyroid-specific genes like sodium iodine symporter, thyroglobulin, TPO, etc. These are the cancers that you're familiar with, like tall cell variant papillary cancer, conventional variant papillary cancer, and the RAS-like tumors are more histologically follicular, so they don't look like papillary cancer under the microscope. They're also less clinically aggressive, and if you look at them at a genetic level, they continue to express, they maintain expression of these thyroid-specific genes. These are tumors more like NIFT-P and follicular variant papillary cancer, as well as follicular thyroid cancer. So this is really the first step toward graded risk stratification, where we see that a genotype can correlate with behavior of the tumor, where it's either more aggressive when it's more BRAF-like, or less aggressive when it's more RAS-like. And indeed, if you look at a scheme like this, the clinical grading scheme from the American Thyroid Association, which ranks tumors, cancers, based on whether they're low risk or high risk, based on a wide variety of features, and you overlay these mutations, you see very much the same thing. The less aggressive tumors tend to be the ones that are RAS-like, which includes the RAS mutation. Intermediately aggressive tumors are more of the BRAF-like tumors. And what's interesting is that the tumors that are most aggressive, most invasive, most likely to metastasize are these tumors that have combined multiple mutations, typically BRAF and TERT, a telomerase mutation, or RAS and TERT, or occasionally you'll see tumors that have multiple mutations like RAS, PIK3CA, and TP53. So these tend to be the very aggressive tumors. So now in 2019, using this next generation approach, there are tools where you can have both a very high negative predictive value test, where a negative test result means that the tumor is actually very likely to be benign, a very high positive predictive value test, meaning that when a mutation or an alteration is present, it's good for ruling in cancer. And we also start to see that we have genetic markers that allow graded risk stratification. This method was validated in a recent publication in JAMA Oncology in 2019. This was a prospective double-blind, multi-center institutional study, 10 centers, including one in Singapore. Patients were accrued over 2 years. It had Bethesda 3, 4, and 5, so these are all the categories of indeterminate. There was central pathology adjudication of the specimen, and the primary outcome was the presence of cancer or NIFT-P in the operated surgical pathology. It included ultimately 234 patients with 257 FNA samples, primarily Bethesda 3 and Bethesda 4, and very few of these Bethesda 5, which are the suspicious for malignant cell aspirates. So what was the result from this study? The negative predictive value was extremely high, 97%. And what this means is that with a negative predictive value of 97%, there's a 3% residual risk of cancer, which is effectively equivalent to a benign aspirate, to a benign biopsy. And it's important to also note that this occurred in 60% of the indeterminate specimens. So it's a very common finding that there is no mutation. The other finding was that the positive predictive value was a very robust 66%, which meant that when the test was positive, disease was very likely present, and in this study, it occurred in about 2/3 of the cases of positive test results. It was also highly valid in Hürthle cell type tumors, which you've heard through the meeting can be a very challenging group of tumors. It included both benign hyperplastic Hürthle cell nodules, Hürthle cell adenomas, and Hürthle cell carcinomas. The test was able to correctly diagnose the hyperplastic Hürthle cell nodules as benign 100% of the time. It correctly identified the Hürthle cell cancers as malignant or suspicious 100% of the time. And it correctly identified the adenomas as negative 60% of the time, with 40% being identified as gene test positive. So the summary of the test is that we now have several methods that are available that are very high negative predictive value tests. They're excellent for ruling cancer out. We have also a very robust positive predictive value of 66%, which makes this test a very useful test for ruling cancer in. It performs well across all tumor types, including Hürthle cell cancer. It's been well validated. And it also suggests that tumors can be graded by risk, with the highest risk being associated with these complex driver mutations, more intermediate risk with these BRAF-like tumors, and lower risk with RAS-like tumors. So how do we apply that in a clinical sense? So this is a 55-year-old woman with a 3-centimeter nodule, which you can hopefully see is in the right isthmus junction. She's otherwise healthy. This was noted completely incidentally, but it turned out after it was noted, she said it bothered her. She didn't like the way it looked. She's euthyroid, but she has some mild symptoms, and she would like to know if there's a way to treat this without surgery. She doesn't want to have a scar on her neck. So of course, the first place to start is with cytology, with sampling. So multiple FNAs were done on this nodule in 2016. The result was suspicious for follicular neoplasm with Hürthle cells. So this is an indeterminate diagnosis. And in 2016, with an earlier form of the test, it was negative. As time went on, we decided to biopsy this nodule again, and it was again suspicious for follicular neoplasm with Hürthle cells, again indeterminate, and again gene test negative with the most recent version of the test, the data for which I just showed you. So the first provocative question is, should we offer minimally invasive therapy to a patient with a cytologically indeterminate nodule? So this is not benign, it's indeterminate, when the gene testing is negative. And I think the answer gets back to this question about, well, what's the negative predictive value of a negative genetic test? And in this case, the negative predictive value is about 97%, meaning that there's a very small risk of residual cancer. These are typically low-grade tumors when they occur, and this is effectively equivalent to benign cytology. And in case anyone still has some lasting anxiety about whether we should treat this patient with a minimally invasive therapy, I can tell you that I rebiopsied this tumor again in 2019, and this time it was read as benign. So I think truly this is a low-grade tumor that the molecular diagnostic testing is confirming. So I would propose that for an appropriately selected patient, minimally invasive therapies can be offered for cytologically indeterminate nodules if a high negative predictive value test is indeed negative. What about this case? This is a 32-year-old woman with a 9-centimeter biopsy-proven papillary cancer, which I think you can see here. Now, I will tell you that if I saw this image, I would say that that tumor is very likely to be BRAF V600E positive, because this ultrasonographically looks like a classic variant papillary cancer. And the most common mutation in those tumors is BRAF V600E or something similar to BRAF V600E. This is a healthy 32-year-old woman. She's asymptomatic in euthyroid. The rest of the ultrasound is negative. There's no evidence of malignant adenopathy. And as I said, the BRAF V600E mutation is not surprisingly present. She also doesn't want surgery. So what to do in this case? Well, we know if we place patients like this into an observational management protocol, from data from Japan and from Korea, that a small number of these patients will develop metastatic lymph nodes over long periods of follow-up, and that's a disqualifier for continued observation. And generally at that point, these people are pushed out of the observation arm and they go to active management, which is typically surgery. And we know from Mike Tuttle's data from Memorial Sloan Kettering that if we're talking about size change, and there's data like this from Korea and Japan as well, so this is just one study that I'm showing you, but if we're talking about size change where we're talking about a greater than 50% increase in volume in the purple bars, or a greater than 3 millimeter increase in tumor diameter, that we also see progression over relatively shorter periods of time. And I think the interesting thing about this study is that we see the greatest progression in the younger aged patients, so patients in their 20s, 30s, and 40s. So this is an interesting observation. So I think many would agree that observational management is reasonable for small, appropriately selected papillary cancers. We know that some papillary cancers will progress over time, especially in younger patients, based on the data I just showed you. So the next provocative question is, can we use molecular diagnostic testing to improve selection of these small papillary cancers for observational management? And I think the answer is perhaps. So I think what we can say is that if we have a papillary cancer, and if we do have molecular diagnostic testing, and it happens to be one of these tumors that has one of these particularly aggressive genotypes, like compound driver mutations or multiple driver mutations, I think it would be fair to argue that these patients are most likely to progress over time, that this genotype is associated with the most aggressive disease, and perhaps it would be reasonable to hypothesize that these patients would be least amenable to observational management. However, those types of tumors are very rare. The more provocative questions I think that we're left to ask is there a molecular profile associated with a greater risk of progression? And if we treated those patients with a minimally invasive approach early, before the tumor enlarged, before metastases developed, would that represent definitive therapy for that tumor? And could we decrease the risk that these tumors would eventually go on to evolve and develop metastases or increase in size? Conversely, is there a molecular profile associated with truly indolent papillary thyroid cancer for which we should perhaps never offer minimally invasive therapy because the risk of progression of that tumor is so incredibly low? I'm not sure I know the answers to that, but I think they're important questions to ask. Excuse me. I think the summary is that diagnostic molecular testing for cytologically indeterminate nodules is definitely accurate and very clinically useful. Specific molecular profiles can assist us in making a graded risk assessment and also possibly inform the use of minimally invasive therapies. I showed you an example where cytologically indeterminate nodule that had negative gene testing is extremely low risk, and I would propose that that's a reasonable nodule to treat with minimally invasive therapies. In the rare circumstance where a truly aggressive genotype is present, those tumors would probably not be ideal candidates for observational management. And I think there remains a lot of open question about whether there are genotypes that we can identify that will identify the nodules for which minimally invasive therapy would be very well selected and appropriately indicated. I think there remain numerous questions about cost effectiveness and efficacy of these approaches. I think many of these questions will only be answered by clinical trials. And the last comment I would make to this group is, what are we waiting for? Thank you very much.
Thank you very much, Steve. That was a beautiful argument for the use of genetic markers. And now this presentation is open for questions or comments. Please approach the microphone and introduce yourself before asking your question.
Carmelo.
Carmelo Barbaccia, Dubai. Congratulations for the excellent presentation. In view of the excellent achievement now with this test in 2019, do you think we should offer to all the indeterminated nodules these tools, or we need to stay with the American Thyroid Association 2015, which should be only suggested in selected patients?
Yeah, so the question is, should we offer molecular diagnostic testing to all indeterminates? Yeah, I would say yes, because I think what we find with, so the old paradigm for managing indeterminate nodules was they all went to surgery. As Rick Luce pointed out last night, about 80% of those nodules that went to surgery ultimately proved to not have cancer, which means that in 80% of the cases, we did surgery on benign disease. So if we can use molecular diagnostics to identify those people very likely to be benign, I think it's a very strong argument to keep them under some form of observation and not treat them with surgery. And then the patients that we do refer for surgery will have a much higher risk of finding cancer or NIFP at surgery. So I think yes, the answer is yes, we should be using it in all indeterminate cytology cases.
Thank you very much.
Hello, Erivelto Volpi from Brazil. Very interesting topics that you put on the table. It's very interesting. I just want to do a small comment. We have two patients, Bethesda 3, that wants totally avoid the surgery, and we perform molecular tests, and we perform after negative tests RFA. And the behavior of these patients are exactly the same of those who are Bethesda 2. So perhaps there is really a good there is a good option for those patients to want to avoid surgery with Bethesda 3 or 4. But do you think there is some molecular profile that you can do after the RFA? Do you think there is another avenue that we can go after perform RFA for patients with molecular profile negative, molecular tests negatives?
So you're asking if it's reasonable to do radiofrequency ablation on patients who have a negative molecular profile?
Yes, and then after the RFA, do you think there could be any change in the...
So could the RFA induce a genetic change in the nodule?
No, not genetic change, but in the behavior of the nodule.
Well, I mean, I think at the end of the day, the point really is, are we dealing with a neoplasm, meaning that we have a clonally expanded lesion that starts from a single progenitor cell that enlarges? And that's what molecular diagnostic testing is looking for, is whether we're dealing with clonal neoplasms that develop invasive features, in which case we call them cancer, or if they're just clonal neoplasms, which we may call a benign adenoma or a NIFP or something like that. I don't think that's going to change because of the RFA. So I think if we're doing the right kind of molecular diagnostic testing before the procedure, we can be very confident that if the test is negative and it's a good test, that we can proceed with minimally invasive therapies without a lot of concern. All right, I think
Thank you very
I'm in
much.
trouble now.
Very impressive talk. My question is reverse. We definitely confirmed benign lesion and performed RF ablation when the tumor regrow.
Right.
So what about the think about this situation?
Yeah, so I had that thought also during one of the presentations.
Yeah.
I mean, I don't know the answer, but I think I would hypothesize that when we're talking about a tumor regrowing, we're talking about a neoplasm that's expanding. And this is not likely to be regeneration of a hyperplastic nodule, but I think the only way we would know is to do biopsies and to see.
Yes. Current evidence shows when the RF ablation was performed for indeterminate cytology, it can be cancer after regrowing. It can be cancer because adenoma can change it to follicular cancer, but definitely benign lesion, at least 2 times, as the guideline suggested. After RF ablation, sometimes benign nodule can grow again, but final pathology is almost always benign. So I would say RF ablation does not induce neoplastic change in benign thyroid nodules.
I think that's right.
Thank you to the speaker. Thank you, Dr. Horak, and to all the question